Okay. So now with no further ado, I will turn things over to our amazing ID pharmacist, Kristen Kilcrease, who's been getting access to injectable medications for our patients in a way that is really amazing. And we're all very fortunate to have you leading our efforts in these areas. So go ahead, Kristen.
Thanks, Eileen. Hi, everybody. Thanks for having me. Just wanted to come and provide a update on injectables, where we are in clinic in terms of our procedures and standard operating procedures and rollout. And so let me go ahead and start to share my screen. Let's see. Okay. Uh-oh. There we go. All right. Can you guys see my screen?
Looks great. Yep.
Okay. All right. So thanks again for having me. Today we'll just be discussing where we are in clinic in the Bartlett practice and other practice sites with our injectables, our injectable antiretrovirals, and talking a little bit about the referral process. And we're going to touch a little bit on just a very broad overview of the benefits verification process. I know I get quite a few questions from providers when we have to kind of backtrack through benefits verification, as well as talking about a little bit about therapy plans and how you guys can navigate that. So the injectable antiretroviral therapy options that are currently FDA approved, that we have a good amount of access to, are cabotegravir rilpivirine for HIV treatment, cabotegravir for PrEP, lenacapavir, and then ibalizumab. We won't really talk a whole lot about lenacapavir and ibalizumab. Lenacapavir right now, it's been approved. It is on the formulary for outpatient use only with financial clearance. It's making its way through the EPIC builds right now, and so we're hoping to potentially have actual access to it either later this month or early August. Ibalizumab we won't talk about really because it's not offered in Bartlett, but it is offered in Park Infusion Clinic up above us. And so if you have a patient that is eligible or you have questions about this process, please feel free to reach out to me. So in terms of our operations that we have, obviously cabotegravir rilpivirine for HIV treatment is live in Bartlett. It's been live since August of 2021. Good news is that we are going live with it in Harriet Lane in about a couple of weeks. So very, very exciting to be able to offer that to the adolescents instead of them having to come over to Bartlett for those that are weighing at least 35 kilograms. And then we are live with cabotegravir for PrEP in the pharmacy side of things. We're working on getting it live for the clinic. We're still working through some operations there. It's a little bit harder to get things going with the clinic side, just based on the need for a therapy plan and making sure all of our ducks are in a row with the therapy plans. So currently our operations, we start off with a referral system that patients get placed on the waiting list. I think we talked about this back in November when we first kind of had our first update. And it is a date-based waiting list just so that we can organize the patients in first come, first served basis. And so we've now switched to having providers to screen their patients prior to referring them over to the waiting list and discussing and educating their patients on either cabotegravir for PrEP or cabotegravir rilpivirine for HIV treatment. So we are now fully staffed to administer. We've got two wonderful nurses in the Bartlett Clinic that are administering every day except for Thursday morning. So Even then, I checked our schedule, and I was like, whew, those are filling up fast. And so we've got Stephanie Thornton and Calla Lopez that are leading the charge in the clinic to administer injectable antiretroviral therapy to patients. We have pharmacists that are administering it in the pharmacy space. We completed our injectable antiretroviral therapy room. And so that, I'm not sure when we actually completed that, but it is a wonderful addition to be able to increase access to our patients who have to receive the medication through their pharmacy benefit. So Hang is offering that 3 half-day sessions each week. I'm sure if her capacity starts to fill up even more, we'll discuss additional options. We are working to get more pharmacists trained to administer the medication. So we are constantly looking to increase our capacity to offer this medication to any patient that is eligible for it. So right now, what our rate limiting steps are insurance approval times. What we're seeing is that insurances are giving us a 30 to 60 day kind of approval processing time. And so sometimes it comes back quicker, sometimes it takes a little bit longer depending on, kind of what their review process is. And then we also we've been having a little bit of difficulty reaching our patients to schedule them for injection appointments. And so I think that's kind of a point of, if you can talk to your patient beforehand while you're referring them and say, hey, if you receive a message from the pharmacy or the clinic, just be sure to return that so that they can get you scheduled on time for your injection appointment. So those are our kind of biggest barriers right now to getting patients started on a timely basis.
And Kristen, in terms of I have just 2 quick questions. So for the half-day sessions that the pharmacists do, are those in the afternoon, just thinking about patients for whom it seems like if you can't come in the mornings, this might not be an option for you?
That's actually a good question. I think I don't want to speak out of turn. I'm not sure if Hang is on or not, but I think she does have an afternoon session, but I can double check with her.
And not that, I mean, if it's a barrier, it's a barrier, but just, there are some people for whom only certain timeframes work. So would be like feed into our considerations.
Yes. Yep.
Kristen, correct me if I'm wrong, though, aren't only patients whose benefits are through pharmacy benefits getting injections in the pharmacy, or can patients with the medical benefits also get injections in the pharmacy?
No, if they're getting it, if it's going through medical, it has to go through the clinic.
Yeah.
So that would mean, as of now, if you have a job that you can't get to clinic before 1, in theory, you're not eligible for this treatment if you have medical benefits.
Correct.
Okay.
I'm sorry, I may have missed that. Yes, that is correct.
Okay.
But I feel like, we can talk to Sheila and Kala and Stephanie, right?
Yes. They are all wonderful.
Yeah.
But as of right now, it's just being offered in the mornings.
Yeah, but I think that if that's like a real limitation, then we should have a conversation. So, and a big part will depend, as I think Kristen's going to show, what type of benefit the injectable ART is covered under, if it's under medical benefit or pharmacy benefit in terms of location.
And then in terms of the rate limiting steps too, there on the last bit about reaching patients to schedule, I think that's huge. And is like, I think for many of us, like whether it's mammograms or Cabenuva, that's like a huge problem. So I think that's really great. And I think I guess the ways we could best help with that is it might help to reach out to the provider for assistance in that scheduling, because like, for example, I know certain patients I have to call twice because their phone will block the first call, but if you double call, it'll go through, like those kinds of things. And I'm sure that providers would be willing to help in the outreach process if that's well, I say that, but I think that's true. I think, I know that like there's often a big space between when they're seen in clinic and when all this stuff can be mobilized to allow this to happen. But I certainly wouldn't mind if like a touch came back to me to reach out.
Yeah, and we've done that in the past, and we've had great response from the providers, and them being helpful in reaching the patients after several attempts. And so it's been great. It's just maybe we need to adjust how many times we're trying to reach the patient before we actually reach out to the provider, so that it doesn't take us as long to reach that patient. So that's something that we're constantly evaluating. Okay, so I wanted to give an update on our numbers, where we are since our last update in November. And so when we first talked in November, we had a total of 60 patients that were receiving long-acting cabotegravir or rilpivirine, with 16 of those patients receiving it through the pharmacy, 34 in the clinic, and 8 at Green Spring. Our wait list was a lot longer, and at that point, we had 4 patients that had discontinued for the below reasons. And then when we first kind of started talking about, hey, let's do another update for the providers back in June last month, I took a look at our numbers, and we were at 82 total patients that were receiving. Between November and June, in May, we actually had patient financial services to come on board and start to help with the authorizations that go through the clinic. And so, it took a little while for them to get on their feet and to understand our process, but they have been helping out drastically. And since that time, and I think they are on a pretty good roll, and you'll see that in about a 3-week period, we have started 22 patients on injectables. And so we're at a total of 104 patients receiving long-acting cabotegravir rilpivirine for HIV treatment. And the majority of that increase comes from the patients that are now receiving it in clinic. And so we've got 61 patients started in the Bartlett Clinic, and we have 6 patients receiving it through Green Spring Station. In terms of our waiting list currently, as of today, we have about 45% of patients that either missed their screening appointment with me. Kind of when we first started this process, we implemented a kind of clinical step for the pharmacist to do a secondary review of patients, to look at drug interactions, double check, hepatitis status, things like that. And so with that clinical step, about 45% of the patients that are still on the wait list have missed their appointment, or we haven't been able to contact them. We're working on reaching out to the providers so that those providers can reach out to their patients and see if they're still interested in the medication. 14 patients have holds on them on the wait list for various reasons. We've got a couple of patients that were on the wait list. When we contacted them, they stated that they were pregnant. We're verifying some resistance patterns on a couple of patients. And then, we've had a couple of patients we've reached out to that state that they want to talk to their providers a little bit more about the medication before getting started. And then lastly, we've got 16 patients that are currently pending insurance approvals. Again, Patient Financial Services has stepped in to help us with the approvals that go through the clinic side of things, so the medical benefit side of things. Previously, Lori Hawthorne and Taylor Allen, the PSCs, were actually helping to get those authorizations done. So that was a huge lift and weight off their shoulders. But they were magnificent, helping us in the early days. And then we've got five patients that are pending insurance approvals through pharmacy. So.
And Kristen, just on those points, I know I have one patient who's, I think, on a pending insurance approval, and it's in part because her insurance statement came back, well, the response from insurance, and I don't know whether it was pharmacy or medical, was that she needed to have failed other options.
Mm-hmm.
And we did not have like appropriate documentation in our notes to suggest, and the last time we were on this call, I think Joko had suggested, he had started including some language in notes of like, patient reporting pill fatigue and pill burden have become onerous. I just wondered if there was any follow-up, or if you're aware of any like sort of trends in approval in terms of, because to me, like that, like obviously the patient has not failed other regimens, they're suppressed.
It's a double-edged sword for sure. And so I can't say that we've noticed any true trends, just because each payer is different. There's so many different payers. I mean, we got a rejection back that was very strange this morning. You know, and when I called in about it, it wasn't what was stated in the paperwork, but we would have never found that out until we called in. And so I would agree with what Joe said in terms of, you know, if patients start kind of stating that they're having pill fatigue, kind of including that documentation early on, so that it's there as a potential rationale for them needing an injectable.
Anyone else on the call with experiences with successful appeals or this kind of documentation?
I would say it's getting harder with the insurances requiring you know, patients to having tried and failed certain regimens. You know, I try to use the literature as much as possible. So if, you know, the patient has stated somewhere in their chart, maybe with another provider, that they're concerned about weight gain, then, you know, I look at the INSTIs, I look at TAF, or if they have kidney issues, I look at those things to try to help facilitate the approval of the medication for them.
And there was just one other question in the chat that I think Joyce might know the answer to, but which is what is our total patient volume? So like what proportion does this 104 represent? Does anybody?
So we're like around 3,000 patients.
Okay.
Yeah.
Okay. So for our cabotegravir for PrEP, we really just kind of got started we just kind of went live in the last month or so. And as of today, we've got 2 total patients that are receiving cabotegravir for PrEP through the pharmacy. And then we've got 2 additional that we're going to start next week and the week after. And so it's exciting. It's not a huge demand right now for it. We've got 12 that are on a waiting list for, and you can see the breakdown of the waiting list. But if you do have, you know, if you do have patients that are interested in cabotegravir for PrEP, please feel free to send them over to be put on the waiting list, and we'll get to them. When we do get started in clinic, Patient Financial Services is also going to help us out with authorizations for the clinic side of things as well. So again, right now, that's kind of why we've got the 6 pending clinic authorizations, because it takes us a little bit more because of the therapy plans that are required through the clinic to get things started on the clinic side of things.
And Kristen, so were those, do you happen to know if those were patients who came in for just for PrEP, or if they were patients who were on new PrEP, or were they patients who were on PrEP who are rolling over from an FTC TAF or FTC TDF based regimen to CAB?
A lot of them, I would say, are already on PrEP and rolling over. There has been 1 or 2 patients that was specifically interested in long-acting cabotegravir. And when they came, you know, we were nowhere close to offering it, but I put them on a waiting list and said, hey, we'll reach out when we get a little bit closer. So I would say the majority of them are on oral PrEP and want to roll over.
And the patients who were specifically interested in injectable, just out of curiosity, do you happen to know if they were like, I don't want to take a pill every day, but I would do this, or if it was just in thinking about like what the drivers are for uptake of this particular modality in the PrEP population?
The ones that were specifically interested in injectable stated early on they had issues with taking pills, either difficulty swallowing or their fear that they may forget to take the medication, and they're at high risk for HIV acquisition.
Got it. Thank you.
So just a general process overview of kind of what we'll talk about to continue the discussion. And so this is our overview of our process of provider review and referral of the patient. The pharmacist still does the secondary review once the provider has referred the patient over. Once the secondary review is completed, there's a status change in the wait list for that patient that kicks off the benefit review. And once the benefit review is completed, the patient is approved for the medication and they are scheduled for their injection appointment, and then obviously follow-ups. So this may look familiar from, again, the update that we did back in November. I just kind of talked through this, but to give another visual for the audience, our implementation team is Stephanie Thornton, Sheila Goldscheider, myself, Matthew Langle. Oh, and I forgot to add Hang Dolly as well as Kyla Lopez, but they are also very instrumental. So for the provider review resources, I created an Epic Smartphrase for providers to utilize. I recognize that it is quite wordy, but I created it with the thought that it could help facilitate discussion with the provider and the patients and talking about the clinical trials, the failures that we saw in those clinical trials, reminders about resistance patterns to look for, and thinking about, does the patient want a oral lead-in, things like that. So I'm actually working to create a more simplified version of a referral form so that providers don't, if they don't feel like utilizing the Smartphrase, they don't have to, they can just fill out the simplified referral form that is on the right. So either form can be sent over to the implementation team. So if you like the Smartphrase that's created, that's on the left, feel free to use it. I've added all of the providers to that Smartphrase, and so you should have access to it. It's .Cabenuva in Epic is how you can access it. So now we get to the interesting part with the benefits overview. This is where we get kind of the most questions, and I want to give, we'll go over kind of just a broad overview, and then I created a more in-depth view of kind of what goes on behind the scenes. And so this is, again, from the update that happened in November, and so to kind of orient the audience, patients are screened here by their providers or by myself, and provider will send a prescription to the pharmacy. The pharmacy benefits are billed because that's a little bit easier of a process for us to determine on the front end. If a PA is required, then we'll pursue it depending on how that results. If it's approved, it'll go through the patient receiving the medication through the pharmacy. If the prior authorization is rejected, there's an appeal that can happen. If the appeal gets rejected, then we will send it over to the clinic side to explore the medical benefits using a therapy plan. And so when we enter the therapy plan, the nurses actually enter the therapy plan here. Once that therapy plan is pinned over to the provider and signed by the provider, that automatically shoots it over to what is now Patient Financial Services, who will explore the authorization requirements for the medication. If it's approved, then the patient receives the medication through the clinic side, and the nurses administer it. If it is rejected, then our only other option is to potentially pursue a patient assistance program. And so if the patient is still wanting access to the medication. So just to kind of drill down a little bit more on what we just talked about and kind of what we'll be going into, we confirmed the provider has screened and discussed the medication with the patient. Once we've confirmed that, we've changed the status in the wait list so that the pharmacy can initiate the benefit verification process. We do know how some payers will cover the medication, if they will cover it through the pharmacy benefit or the medical benefit, kind of through our work of trial and error. But we only know some of them, not all of them. Some payers do not give us a clear message. And so sometimes that's where the providers kind of get caught up in kind of a backtrack of sorts when the messaging isn't very clear. So if that happens, we're still trying to figure it out and see what is it that the payer is actually asking us for. Are they asking us to go through the pharmacy benefit, or are they asking us to reroute and go through the medical benefit? So I recognize that this is hard to see, and I don't plan to go through the schematic completely, but I want to give you a more in-depth view of some behind the scenes benefit verification process and point out a couple of key components. So pictured are the different pathways that we can take to get coverage through either the pharmacy benefit, which are the purple boxes, or through the clinic, which are the teal boxes. The green oval at the top represents when we change the status in the wait list from waiting to let's go ahead and start the benefit verification process. And then prior to its, once we change that status, then a test claim is actually sent by Hang. And so she's actually able to try to figure out, before we have the provider send a real prescription, she's able to try to figure out how the payer may cover this medication. And so if it comes back approved, then obviously they're going to go through the pharmacy side of things. If that test claim is rejected, the gray boxes, the 4 gray boxes actually represent the most common kind of rejection messages that we get back, which are not covered, formulary alternatives, prior authorization required, or product not on formulary. And so based on those kind of rejection messages that we get, we can take different pathways for trying to get the medication approved. Any questions there? Okay.
So Kristen, one question in the chat was just about how long a patient has to be suppressed in order to be referred.
As far as if we're talking, as far as clinical trial, they were suppressed for 24 weeks or 6 months. If we're talking about payers with payer requirement, I don't think payers have specified a certain time frame. Some will, some haven't, that I'm aware of.
Got it. And that would be relevant also for patients who are using it. And so from an off-label perspective, the payers haven't necessarily been reviewing for viral suppression.
They review for viral suppression, but they
Not
don't
duration.
specify duration.
Got it. Okay.
So we've submitted, a patient who's been viremic, and they just said, oh, this patient's viremic, and we appeal with, why. So. And then just as a kind of summary, if a patient's insurance covers it under the pharmacy benefit, they'll receive it from Hang or one of the other pharmacists in the Bartlett pharmacy. If it goes through the medical benefit, then a therapy plan must be sent, and the nurses are the ones who are initiating those therapy plans and embedding the labs, and then pending it over to the providers. So from what I understand, therapy plans are a relatively new tool for our clinic. And so I wanted to discuss some key takeaways with therapy plans. We won't go into a lot of detail about them, but just kind of wanted to give a broad overview. So as I just mentioned, the nurses are the ones who are entering the therapy plan. That doesn't mean that the providers can't, but based on our workflow, it's easiest for our nurses to do it because they know when the patient's status has been changed in the tracker. in the wait list. And so our current workflow is that the nurses enter the therapy plans. They also enter the labs, the routine monitoring labs that go along with either HIV treatment or HIV prevention. Once the nurses have entered the labs, they'll send the therapy plan over to the provider for the provider to review. That therapy plan ends up in the provider's in basket on the left-hand pane. It falls under a tab that is non-oncology therapy plan. Once you see that, you should double click into the encounter, review the plan. There are no pre-medications, but there are your standard hypersensitivity protocol and medications that are in there. And so they're already defaulted to be checked in case the nurse needs to administer to the patient while the patient is receiving the long-acting injectable. So once the provider reviews the plan, if the provider wants to add any additional labs or other medications, they can schedule them in the therapy plan as well. And then they can go ahead and sign the plan. So the sign the plan box is in the top right-hand corner of the therapy plan or the bottom right-hand corner of the therapy plan. I wanted to also point out this is the name of this particular therapy plan. And so you'll notice that it's black here. Once the provider signs the therapy plan, this will actually change green. So you know that you signed it. It also says not signed here. Once the therapy plan has been signed, then the provider can actually sign the total encounter. If the therapy plan itself is not signed, it does not get routed to Patient Financial Services, who is responsible for taking care of the authorizations and exploring the authorization for the medication. And so we essentially cannot start. And so it's very important that that gets signed and then the encounter gets signed. Any questions there? Okay. So the standard labs that the nurses enter into the therapy plan are here on screen. We've got our HIV RNA, CD4, CMP, CBC. And their frequencies based on the frequency of the injectable. So our monthly administration will do every 12 to 24 weeks standard monitoring, and then for every 2 months administration of the injectable, it's every 16 to 24 weeks. When the nurses embed these into the therapy plan, it's a little bit easier. It helps automate the system or automate the process. And so, if the patient ends up having an appointment with their provider between their injection appointment, once they show back up for their injection appointment, the nurses are double checking to make sure that they, if they didn't get labs with their provider, that they are going to get labs during that injection appointment, or vice versa. If they got labs with their provider, then they won't release them to get the labs during that injection appointment. For the pharmacy side of things, it's a little bit harder to automate, but we've kind of figured it out a little bit. We've been placing standing labs that are appended to the provider for the patient to get each time or when they come back for their injections. And so we're hoping that makes things a little bit easier when we send over the standing labs. It definitely makes it easy if the patient gets their labs at Hopkins. So we're trying to automate the system or automate the process as much as possible. So kind of last thing about therapy plans. Again, once the plan has been signed, you can see that the text turns green. The clinician must re-sign a therapy plan annually. If that's not done, then the nurse cannot release the orders and cannot administer the medication to the patient. Those therapy plans usually are sent about 1 to 2 months prior to the expiration of the therapy plan to be signed by the provider. And then lastly, if you are wanting more information or a step-by-step guide, I put the link for the therapy plans kind of tip sheet here on the slide. And I can send these slides out as well. Natural progression. Once all the therapy plans are entered, the patient has been scheduled, they come for their injection appointment. They are seen by the nurse or the pharmacist, and they do receive reminder calls a day or so before their injection appointment. The nurses and the pharmacist ask the screening questions, and then they administer the medication to the patient. And then they monitor them for the recommended amount of time, and then send them to the lab if any labs are due at that point. And then they have their appropriate follow-up steps where they get scheduled for their next injection appointments. So in conclusion, we are nearing year 2 as of August of offering long-acting cabotegravir rilpivirine for HIV treatment, which is super exciting. I am blown away by the progress that we've made since those first patients. I'm very pleased that we've gotten to 104 patients that are receiving it through the Bartlett, through Hopkins in the health system. Patient financial services is now integrated into the clinic workflow, as I've mentioned many times before. And so they are helping to expedite those authorizations. And then just as a reminder that our providers do need to re-sign their therapy plans annually once those kind of get sent over to your in-basket. As mentioned, I'm working on a simplified referral form so that providers, if they don't want to use the Epic Smartphrase, they don't have to, but you can send that referral form over to the implementation team, and that will initiate the status change in the wait list for the benefits verification process to get started. And lastly, we are working on the standard operating procedures for long-acting cabotegravir for PrEP. So if you have a patient that is interested in long-acting cabotegravir for PrEP, please go ahead and send them over, and we'll put them on the wait list. And we're currently administering it through the pharmacy. So, and that is all I have.
Well, thank you so much, Kristen. And I know we've already had a few questions in there. And so Jeannie Carulli had commented that, 12 waiting, 14 people total, two on long-acting cab for PrEP and 12 waiting, that actually may represent a reasonable proportion of our patients on PrEP. Again, we probably have to defer to Joyce for how many people we actually see for PrEP in Bartlett.
I don't have recent numbers, but it is a high number. We've had many more PrEP patients over the last couple of months. I think largely through the efforts of Kristen and Carmeletta. I mean, there's just been many more referrals. So I don't have updated numbers, but that is a relatively significant number given our PrEP program.
Thanks, Joyce. But I mean, is it it's probably no more than 150 patients.
Yeah.
So it is a lot, because the only reason why I mention this is because there's, the industry, the pharmaceutical industry is doing a tremendous amount of advertising for this, on television. I don't know if they use other media, but all the commercials, when it's being pushed. So it's interesting.
Yeah, Judy, I think that's such a good point, because I think for those of us who were around when PrEP was first started, a lot of the initial referrals were people who self-referred after reading about it in the New York Times. And so this is a different type of patient-driven shift.
Yeah.
And I think depending on where they're being marketed, exactly as Mike is mentioning, places like Grindr or Tinder, where there's lots of access to individuals who might be good candidates. It's really interesting. And I think, one point about it is that the data thus far, as we all know, and I'm obligated to say this, data for PrEP in women in the United States context is lacking, including data supporting the use of TAF-based oral therapy for people who have a vagina as a site of risk. And long-acting CAB actually worked better than oral PrEP in the large studies that were done, not in the US context in sub-Saharan Africa, but something to keep in mind that that is a population in the United States that we are missing, partially due to their lack of identification of being at risk, our added lack of identifying them at risk, but certainly a group to consider. That is also a group for whom we would have to consider the implications of becoming pregnant on long-acting cabotegravir because of the duration of exposure. But again, there's like a lot of thought about this in the HIV prevention space, so it shouldn't necessarily be stopping us from considering it for those patients. Other thoughts or questions? I hate to whatever. I'll just say, I see Christine Durand on the call. So I'm wondering if there's been much crossover of the long-acting drugs into your transplant population. And if you're not able to talk, don't feel obligated.
No, I'm here, happy to talk. I attended because I actually have a panel of patients that have HIV only, and I have a couple of patients on PrEP for reasons that I've mentioned, pill fatigue, things like that. But for ibalizumab, that is one we have used in the transplant population, really without any data. And for all of these, I think it's probably the next frontier. So keeping it in mind, patients who have transplant have a lot of pills, a lot of pill fatigue. So I think it's a good option as we have more availability. And I have to say, Kristen and the team have just been fantastic in making this happen for patients. Even when I've gotten denials for saying they haven't failed, I think it was Kristen came back to me and said, ignore that, and it got fixed without me doing anything. So the team is fantastic at getting authorizations and getting people in.
Yeah, and I think the transplant scenario is one that, when we think about the risk-benefit ratio of some of these agents, obviously you can't remove them should you have to change another medication, but because the drug-drug interaction profile for our long-acting agents so far is relatively favorable, it's overall not presented the kinds of problems we might have worried about if it was like long-acting Darunavir or Cobicistat. That would not be
Yeah,
great.
exactly.
Yeah. I'll just put up briefly, I don't think we have time to do a full case